So hi everyone. The question that I'm tackling today is, what do I do for my patient with irritable bowel syndrome who's been treated with laxatives and still continues to have abdominal bloating? So abdominal bloating is, a burdensome symptom for many patients. There are some epidemiologic studies that have been done in the past showing that there's a 40% to 50% prevalence in the general population of bloating. There is definitely a higher prevalence of this symptom in females, but it's not exclusive to females. Males also experience significant amounts of bloating. And it is a hard symptom for many of us to tackle in our practices. So that's for me included. My area of specialty is motility disorders, and I find that so many of my patients have improvements with laxatives. They may have improvement in their stool consistency, the number of bowel movements that they've had, whether they've had constipation or diarrhea predominant IBS, they may continue to have abdominal bloating, although I feel that the patients that have constipation tend to have more of this abdominal bloating that they complain about. Now, bloating could be a side effect from some of the medications that we use. So, for example, PEG, which we often use for treatment of chronic idiopathic constipation, can itself cause some abdominal bloating. We know that foods are related, so diet is a huge factor. We have this diet called the low Fodmap diet, which is the fermentable oligosaccharides, monosaccharides, and polyol diet. And in this diet, there are a lot of legumes and fruits that have sugars and create this osmolytes within the intestinal wall that can create this symptom of abdominal bloating. We know that bacteria produce, so the gut microbiome is very important. Bacteria can produce gases such as methane and sulfites and hydrogen, and excess amounts of them in the small intestine, a condition we call small bowel bacterial overgrowth, can cause abdominal distension and bloating. Oftentimes, those are the main symptoms that patients will experience, whether they have diarrhea or constipation. Bloating is a very, complex symptom, and it is part of the symptoms that patients who have irritable bowel syndrome experience, but even patients who have just chronic idiopathic constipation without any abdominal pain or necessarily any abdominal discomfort will also experience bloating. Now, the Rome criteria, which is the diagnostic criteria we use to diagnose irritable bowel syndrome and chronic idiopathic constipation, doesn't include bloating as a symptom. Same with gastroparesis. So gastroparesis patients who have delayed gastric emptying and abnormal digestion, these patients will also have nausea, vomiting, but bloating is a significant symptom that occurs in those patients as well. Same with functional dyspepsia. So I think of functional dyspepsia as the upper GI tract syndrome in patients who have, nausea. They may have early satiety. They may have symptoms where they feel like they get full very quickly after meals, this postprandial abdominal pain. Some of them have epigastric burning. These patients will have the symptom of bloating. So it appears to be sensory, but there are some motor issues that also occur in patients that can cause the symptoms. So classically, we think of functional dyspepsia as more of a sensory disorder, and we think of gastroparesis as more of a motor disorder. However, the two can overlap, and so even the symptoms will oftentimes overlap. So how does a clinician then tackle bloating, since it occurs in every syndrome, every disease process, even inflammatory bowel disease, Crohn's disease, ulcerative colitis? So the initial conversation with the patient is very important. So it's nice to be able to identify if there's any triggers in their diet. Is there something initially in their lifestyle? Are they someone who drinks a lot of carbonated beverages? That can be related. Are they having any heartburn symptoms? Are there other symptoms along with the bloating? Is there abdominal distension that occurs? What is their bowel habits like? What is the consistency? How many bowel movements? Are they straining? Do they possibly have like a pelvic floor disorder? Are they using digital disimpaction or changing their position in the toilet with having bowel movements? Are they straining a lot? So any of that history that can be elicited is very important. So a common problem is lactose intolerance, for example, and these patients may or may not have diarrhea or constipation, but they'll have abdominal distension and bloating as a main manifestation, and hopefully you're able to get from their history that they were eating dairy prior to the symptoms. Now, there's also other carbohydrate enzyme deficiencies, and that's sucrase also maltase deficiency, and this can be either congenital or it can be later in life, and there are patients that develop this enzyme deficiency later, perhaps in their 30s and 40s, and there's few studies looking at this to see if this is something that we've been missing. And there is a supplement that patients can take if they actually indeed have sucrase also maltase deficiency. Usually the way we diagnose patients is by a enzyme immunoassay obtained via endoscopy, where we get small bowel biopsies, and from the small bowel biopsies we're able to see if the enzyme is deficient or not. And then there's also a genetic test, but that's more for the genetic version of the sucrose also maltase deficiency, mostly done in kids with failure to thrive. And then there's also a blood test that is done, although it's awaiting full validation in multi-center studies, that hopefully will be an easier way, rather than sedating patients with endoscopy, to diagnose sucrase also maltase deficiency. So let's say we've ruled out carbohydrate enzyme deficiencies. Then we move on to just trying to see if perhaps the patient could benefit from a low Fodmap diet. This is something that hasn't been formally done just in patients who have abdominal bloating, but there are things that we can ask patients to eliminate, such as onions, garlic, and other foods that the patient may be ingesting prior to their symptom onset. And so really the help of a dietitian should be elicited during this workup, as they have for sure much more experience. They have more time to spend with the patient, trying to get their diary is very important, their food diary, to assess what may be the trick. Now, there's also patients that have, allergies. So food allergies is huge. We don't have a fantastic way of testing for those. Skin testing is not really, related to some kind of necessarily bloating symptom. And the skin testing that we do is IgE test, and really maybe IgG testing would be better for this patient. So really that's something that hopefully will evolve in the future. Now, after you've ruled out the carbohydrate enzyme deficiencies, there's not something directly as far as carbonated beverages that the patient's drinking. There's these other phenomena, which are belching syndromes, and what's called supragastric belching, where the patient is swallowing the air and has aerophagia. And with this process, it's purely psychological, and you can teach the patient to really learn how to do diaphragmatic breathing. And there's some videos from the University of Michigan psychologists and others that have been available online that patients can use. So if this is the history that's found, you can do esophageal manometry and impedance pH testing to show that the patient has aerophagia and supragastric belching, but those are really invasive, and hopefully from the history you can elicit if the patient has those. Reflux. Patients who have acid reflux can have bloating. After reflux surgery, one of the symptoms is bloat syndrome. So if the patient has had recent Nissen fundoplication or Toupet fundoplication, that could be a potential etiology. And usually for those, we tell them to do small, low-fiber meals, but soluble fiber usually is allowed. And we try to see if they can hopefully improve their symptoms. Usually 6 months after surgery, the symptoms do improve. That is the natural history. Now, so let's say we've ruled all these out. Now, what are the causes of intestinal dysbiosis or bacterial overgrowth syndrome? Many systemic illnesses, for example, cystic fibrosis patients will have a higher rate of intestinal dysbiosis and bacterial overgrowth, same with scleroderma, lupus, and conditions that affect small bowel motility. And then there's these other conditions such as irritable bowel syndrome, whether or not it's post-infectious, inflammatory bowel diseases, and other etiologies. So usually small bowel overgrowth is a syndrome that comes along with another disease process. And the way we diagnose that is with breath testing. So we have glucose and lactulose breath testing that we can do. There's new tests that also evaluate patients for bacterial overgrowth due to increase in hydrogen sulfides, which may be more related in the IBS-D population. But these tests can easily be done, and the treatment for these is usually either a course of antibiotics or prokinetics or the two together to see if we can help with the intestinal motility and therefore with the dysbiosis, and then treat the bacterial overgrowth. Now, irritable bowel syndrome itself, patients have discomfort. They may have abdominal distension and pain. And so a lot of the neuromodulators that are recommended, so SSRIs and tricyclic antidepressants, are often used in our patient population with IBS, and they do help the abdominal bloating symptom. And then there's the drugs. So the drugs that are secretagogues, these are the lubiprostone, linaclotide, and plecanatide specifically. There's been studies where they looked at the pooled results from the other multi-center studies and looked at specifically abdominal bloating, and those drugs do improve the abdominal bloating. They do have secondary mechanisms where they help that visceral sensation and visceral hypersensitivity that occurs in the patients. And then, so lastly, there's pelvic floor disorders, and then also abdominal phrenic dyssynergia. So with abdominal phrenic dyssynergia, this is a lack of coordination of the muscles of the diaphragm and then the abdominal wall, and the abdominal wall can protrude out, and patients can learn to redo this. Again, that's also the diaphragmatic breathing that psychologists will teach patients how to do. These are GI psychologists that really understand these disease processes, and patients do benefit. So there are outcomes data out there that show that there is definitely a benefit in patients bloating and abdominal distension with these maneuvers. And again, those are also available, on the YouTube or other venues. Now, for pelvic floor disorders, very common, about 30% to 40% of women, but also men, will have some kind of pelvic floor disorder, whether it's related to their pregnancies, vaginal deliveries, or not. And these can be learned behaviors as well. There may be also dysfunction in coordination of the rectal muscles, the puborectalis muscle, or the rectal sphincters with defecation and during expulsion. And so patients will get anorectal manometry testing and balloon expulsion testing in our labs to diagnose this dyssynergic defecation, which is a part of the functional defecation disorders. And this is also a behavior that can be learned with biofeedback therapy and undone, and that also will help this symptom of bloating. And there are studies looking at that, and also the rectal hypersensitivity that is often seen in patients who have irritable bowel syndrome, but also patients that have ulcerative colitis. So these are usually the etiologies we think of. Now, of course, again, medications can cause bloating, and there may be other food items that hopefully will be discovered with the help of a dietitian. So it really requires a multidisciplinary thought process as well as a team that's available that can tackle the many aspects of bloating. And hopefully soon we will have more studies looking specifically not just at the bowel habits, but also this symptom of bloating that seems to be affecting so many of us in the country. Thank you so much.